Everyone to this April webinar, which is on orofacial pain. I want to thank Professor Yetola Femi for agreeing at a very short notice to do this presentation for us. Professor Oyetola is properly Professor Elijah Olufemi Oyetola and is from Ayedade local government area of some states in Nigeria. And he graduated from the prestigious Obafemi Awolowo University, Ile-Ife, with a Bachelor of Dental Surgery, PCHD, degree in 2005. He earned multiple faculty prizes, including recognition as the overall best student in his set, as well as the best student in oral and maxillofacial surgery. Oral medicine, periodontology, community dentistry, and restorative dentistry. And in 2013, he obtained the fellowship of the National Postgraduate Medical College of Nigeria in the Faculty of Dental Surgery, that's FMCDS, oral medicine specialty. He further earned a master's degree in human physiology in 2018. There's a lot of achievement that our speaker have achieved, but for the course of time, we are going to shorten it. He has published up to 48 papers in in reputable scientific journals, both local and international. Please join me to welcome Professor Femi Oyetola, who will be presenting to us this evening the orofacial pain. Thank you.
Yeah, thank you, sirs and Mas. Actually, the leadership of this association, I want to thank you for inviting me. And let me thank especially Professor Olateju for kind gesture and for getting across to me. We've been friends for some time. He has been a nice man. It's just that if you stay with him for a long time, you may sleep, as I used to joke, because of his profession. So thank you very much for this opportunity. Yes, the business of the day, I'm talking about orofacial pain. And that is what I love so much, because as a dentist, every day I see patients with pain. And I start by saying that pain, honestly, is core component of routine life experiences. Everybody listening to me must have experienced pain one way or the other in life. So it's part of life, and the sensory part or the emotional part, and it can affect all parts of the body, can affect everybody. If you are black, you are white, you are president, you are follower, you are leaders, pain is universal and can affect everybody. Of course, pain is an experience which is tagged unpleasant type. Unpleasant means not friendly, not pleasurable, not what everybody wants. And this unpleasant experience can be sensory or emotional type, as I explained earlier, that this pain can be something you get probably because of sensory problem, challenges, or emotional, and associated with or resembling that associated with actual or potential tissue damage. We are all familiar with this definition, but our association in 2020 have been modified, and that modification comes about that it's an unpleasant emotional sensory experience with resembling that. So the thing is that the pain can be associated with tissue damage or can resemble what is associated with. So that gives room for neuropathic pain and emotional aspect. And that's just the modification in 2020 into the definition of pain. Now, as I said earlier, pain can affect every part of the body. Every part of the body where blood flows, we see pain. So my own portion is talk about the pain as it appears in the orofacial region. And this is the pain from the word orofacial, the jaw, the mouth, of course, and the teeth and the mouth. So that is what make this orofacial pain and the face. So the orofacial pain in particular, I'll be, calling it down now, is a public health problem, and it affects significant portion of the population. And especially it's commoner, it's becoming a burden in the low and middle income countries due to limited oral health services, limited personnel around, and we have a lot of quacks adding to the problem. These have been reported by Chala et al. In 2025. And the reason, even pain has been a reason for many people from absent from work. Chala et al. Also reported 15% of people actually become absent from work due to toothache. And even in the orofacial pain associated with sexual performance, when you have toothache, I tell you, it will be difficult for you to perform, even in the other room. And according to Zonon et al., 2008, they even link it to patients with vulvar vestibulitis syndrome. And it's been said that women in particular, is becoming challenging to give their spouse the best, sexual exposure. And of course, this same study also stated that male can still cope with orofacial pain a little bit when it comes to sexual performance than the female. I'm sure the reason is well known to everybody. Impaired academic performance have been reported also among girls that have, orofacial pain. Of course, pain interrupts all activities in the body. So I will talk about, let's see how common this pain is. I said earlier, it's a general problem and it affects significant part of the population. 60% have been reported. The McFarlane 2002 has also reported 26%. Let's come down to our Nigeria here. Omitola and Port reported 18.5 prevalence in 2010. Kuseri also reported 2005 reported 34%. As I see, is increasing. Oyetola here in Ife, with Agbelusi, in 2014, we reported 65% of orofacial pain. And of course, the latest information here by Amo et al. 2024 reported 45.3%. However, most of these studies are clinic-based, and that may be responsible, but even the community-based studies still give values between 16 to 25%. So which means that approximately 1 out of every 4 Nigerians may actually have toothache or orofacial pain. Either they come to complain or not, because most Nigerians will not come until there are complications that affected them and all that. Yes, the sex predisposition is commoner with female. Female have orofacial pain with a ratio of 1.18 to 2.58 to 1. Twice as affected the male is what female experience, according to our 2024. And the challenging issue is that as the pain become more chronic and is not being addressed, there could be depression, tendencies for suicidal tendencies, and stress. In fact, most of the time we have to manage these cases with our friend in mental health. There are some common terms to remind ourselves: allodynia, when pain elicited by non-nasal stimulus, and paresthesia. We all know this. Don't let me waste my time with this. Paresthesia, sensitization, sensitive pain. These are just the common terms that I may be mentioning so that we can just get them as I do that. Now,
What is one? Yeah, depending. Daddy, no, you did.
Sorry, can I go on? Dr.
Ah.
Fadeju, I'm hearing your voice. Okay. Am I audible, sir?
Yes, please, you are.
All right, thank you. All right, thank you. So, classification of orofacial pain. We classify orofacial pain based on some criteria. The criteria 1, which I love to use here, is based on the source of the pain, or source of the orofacial pain. And that is classified as odontogenic. or non-odontogenic. The other criteria to use duration of how pain has been there, we have the chronic, we have the acute. Chronic is in 4 weeks. Some will say in 4 weeks, 6 weeks. And when it's chronic, that means 4 weeks and above, 6 weeks, 6 months and above. And that comes with depression, as I mentioned earlier. Now, to talk about the odontogenic and non-odontogenic. Odontogenic simply means that this pain comes from tooth-related structure, either from the tooth or from the surrounding tissue that hold the tooth in place. So the tooth itself, as we all remember, we all know, it has a portion in the mouth. That portion in the mouth is called the crown, or the clinical crown. Let me use that word. That has the enamel, the dentine, when you put a section, as I show in this diagram. And inside we have the pulp, okay? The nerve, sensory nerve, the pain receptors are here in the pulp. So anything that will lead to destruction of what protects the pulp and then leading to stimulation of the pain of the nerves here will actually cause pain, and that seems to be the most frequent causes of toothache. The other one is the tooth supporting structure, which we call periodontium, and that consists of the gingiva here. We have different parts of them. We have the attached free gingiva, then the bone, alveolar bone, periodontal ligament is also what attaches the root to the bone, and then the cementum, that is the part of the root to which the ligament attaches. So when there's inflammation of any of these structures, okay, it is also odontogenic pain, or there's proper exposure through either the crown or through the root itself. Once the pulp are exposed and infection gets into this pulp, then that's also odontogenic pain. All other ones that have come from remote site, they are the non-odontogenic pain. Now, as I said, that 95% of orofacial pain is actually odontogenic in origin. This has been reported again by Beckcroft et al. 2024. And this is the order in which it happens. So if anybody has toothache, this is the likely order from the recent literature. Number one is pulpitis, that's inflammation of the pulp. That means the pulp must have been exposed. Let me come back a little bit. That means this pulp, something must have broken the edge. Even the Bible says it that break the edge, the serpent will bite now. So when something break it, I will talk about what can break it, what can open this place up, and that is the commonest acute apical periodontitis, which means that the infection at this apex here, if there is a chronic problem here, and then calculate to this site, apical periodontitis, and it causes an acute pain. Then we have dental alveolar abscess. This one now involves the swelling around the gum and between the root and the alveolar, and it involves the alveolar bone as well. Periodontal emergencies, we all know, maybe somebody put, toothpick there and it's causing pain. Dental trauma affecting the tooth itself, made want to use the teeth to remove the bottles, the cover of Coke. That has been discouraged. Some people still do it. I will show you a picture of somebody who tried that. Post-extraction alveolitis, after extraction, if you do it in a very good place, at IDP, they will give you instruction. And if that is not followed, or if proper history was not taken and all that, that could be inflammation. And peritonitis, yes, that is for, I will also show you a picture of this. And these are the common odontogenic pain from tooth. May also state here that average age of patient with odontogenic pain is 37.3 years, and that of non-odontogenic pain is 45 years. Okay, I think I've said it already. Now, let me now give a little example about what happened in odontogenic pain. As I mentioned, the first one here is pulpitis. Pulpitis simply means inflammation of the pulp. So the pulp is inside. As I said earlier, we have the enamel, the dentine. This this is the normal one on the left here. On our right is the one with pathology. either carious lesion or whichever, create a gap here, and the infection gets to the dentin, and from the dentin, it now touches the pulp. Once it touches this pulp, it initiates pain, and the pain is usually sharp, very sharp, very sharp. It will be initially reversible and later become constant, irreversible, and that could be disturbing. If you have had proper pain before, you know it's really an unpleasant experience that you don't want to have again. So now, the common cause of this proper exposure is dental caries. Is that like there's a hole on the teeth that people call it hole on the teeth, and usually as a result of sugar, when you take refined carbohydrate with bacteria, action on bacteria on it producing an acid. So when the bacteria in the mouth act on the remnant of the refined carbohydrate in the mouth, the acid that is produced now dissolves the hard tissues. I'm talking about the enamel and the thing, and then create a room. And that is what the summary of what, because that's why we always preach against consumption of refined sugar. And even if you must eat it, you must rinse your mouth immediately, because it is the remnant that the bacteria can act upon. And of course, if your mouth is clean, the bacteria will not be available. But as I tell you, there's no sterile mouth, so it's better not to take the refined carbohydrate at all, if possible. Treatment, of course, is by filling, and the filling now depends on how the depth of the hole, as I used to call it. If it is just the enamel that has not gotten so deep, you can put either amalgam or composites. We now use most of the time composite filling that are better restorative material now. I'm sorry I couldn't get a good picture here, but this is just to fill it. I can see the filling by a composite in this, and this is better. So initially, before, we used to talk of amalgam at the posterior, then because it's not aesthetic, but now either anterior or posterior, I think everybody is concerned with aesthetics. And if it is a deep one, filling it up will not solve the problem. In fact, we compound it. So what we do is what we call root canal therapy. This will be done by the restorative dentist, and then get access to the canal. After getting to the pulp, they get access to the canal, and they remove the canal with their files, and then extrapolate the pulp, and then prepare the canal, and then fill the canal with appropriate material. And that, after that, they now fill it up, they can crown it and all that. So that is root canal therapy as a treatment of pulpal lesion that could not be resolved by ordinary filling. Either pulp capping is not good. I wouldn't want to go to that extent. Just know that if anybody has sharp pain, disturbing pain, headache, and you see a hole in the teeth or anything getting access to the pulp, it is pulpitis and you need urgent treatment. In some cases, extraction may have to be the way out, especially if there's mass destruction, is irrestorable. But let that decision be taken by restorative dentists. They're the one that will tell us whether they cannot restore the teeth or not. Secondly, as I mentioned, that if it is not from the pulp, it is from the periodontal periodontitis, as I told you, inflammation of the tooth supporting structure, and most of the time, what destroys them is the effect of the bacteria and the plaque, okay, releasing the toxin on the periodontal tissues. And so, routine scaling and polishing, just cleaning the mouth. That's why we advocate at the end of this lecture, scaling and polishing and routine brushing technique proper as a way of preventing this orofacial pain. Root planing may also be done after assessment by the periodontologist. Periodontal surgery of this time may be, and of course, the medication, which we all know, antibiotics, and then analgesic and other supportive therapy, as the case may be. Cracked tooth syndrome is another thing that can cause orofacial pain. The tooth is cracked, probably after eating, maybe we just eat stone by mistake or whichever, and then it cracks. They can have a simple crack or complex crack, and the pain is usually bad because there's a direct access communication to the pulp. And most of the time, the dentist, it's difficult to diagnose because you are not actually seeing the direct communication, but there are methods the dentist will use to identify this condition and then treat. There are different treatment methods. So, but at least to know that when you eat bone and you cannot see it and you just crack it and all that, you can have cracked tooth syndrome. And it's also another cause of the orofacial pain. Another one is tooth wear lesion. We can see maybe tooth wear lesion. We have 3 examples. Attrition, maybe when the upper and lower teeth are not well arranged and they are grinding on themselves. When the tooth is grinding on another tooth, and that is wearing away the protective layer, as I mentioned earlier, and then exposing the pulp. And you can see this one, the closer, see this one at the gingiva here, as the cervical margin here. And that is causing problem, and the proper exposure will always lead to pain. Tooth wear lesion, number 2, abrasion. Maybe this is from foreign substance, maybe brushing techniques. Instead of brushing normally, which I'm going to explain at the end of this lecture, just brush to expose the root and expose the, just open the pulp here, as we have seen. So this can also cause very bad pain that the patient may have to rush to A&E. Yes, this guy was trying to remove bottle of can, bottled Coca-Cola, and this is what happened. So this shouldn't be tried. So the chips or broken teeth is another thing. Once this happens, traumatic experience, and then there will be proper communication, and then we have orofacial pain of odontogenic origin. Sometimes we have avulsed it through maybe trauma, whichever. So there are things to do. Pick the crown, rinse it with clean water, place it back gently inside, and then please run gently to the nearest hospital where we have periodontics and can actually assess and do the needful. Yes, other causes of orofacial pain of odontogenic origin is pericoronitis. You know, the last tooth, what we call wisdom tooth, you can see in this under another diagram. Sometimes it doesn't come out fully or in the oral cavity. So the flesh covers it. That flesh that covers it is called operculum. So the upper teeth may then be banging on it and then pressing it and then traumatizing it and then cause inflammation. And more so that there will not be space between the flap and the tooth. That would where bacteria can then stay and then cause inflammation. Sometimes it can even be the beginning of some other problems in the oral cavity. It can even cause space infection. Even some lesions, some tumors are linked to impacted teeth. But leave that as it may. When there's some inflammation of this flap covering impacted teeth, is a very good, is a common cause of orofacial pain. And of course, the frequency, I mean, the prevalence is actually high, it's getting higher now. The report I reported earlier that 1% actually must have been underreported because it was done in an area where this pericoronitis is not common and been linked to malaria, stress. And the study was done in UK, United Kingdom, and maybe that was why. But I'm sure in this part of the world, I've been looking for local studies, but sorry, I couldn't get before of the short notice of this, that it is, but I know it's higher than what has been said. Patient menstruation, stress, pregnancy, malaria, or physical stress, generally, they are processed. Of those on oral contraceptives and the rest are predisposed to this pericoronitis. And the treatment is simply actually remove the operculum and then allow it to grow. So, I mean, and then give medication as usual to enhance the option of
ẹnìkan tí wàá bí mí lẹ́nu ẹ̀yin náà sọ bẹ́ẹ̀ ẹ̀yin náà ṣe ń sọ yẹn náà ni.
We have been cut off. Somebody else seems to be talking there. I can't hear you.
Sorry, it seems as if our presenter is having some network challenges. He will be back very soon.
Sorry, I think it's my, let me share again. Sorry, am I back now? Can you hear me, sir?
Yes, you are back now. Thank you.
All right, thank you.
And we can see
Thank
your
you.
slide also.
Yes. The rain is falling heavily here in my house. That's why. So as I said, dislodgement of these orthodontic appliances can also predispose. And I said many times, all these appliances can get dislodged and then impinge on the oral mucosa, causing problem with breathing and all that. And for many cases, patients been reported even in emergency to see. So the call hours of dentists could be as busy as this, and they could be life-saving as well. Okay. The non-odontogenic pain now. I think I've said a lot about non-odontogenic means that this pain is from other structures apart from the tooth and tooth supporting structures. We all know that the whole body is connected. The mouth is not alone, so there are many structures that also form part of the mouth, orofacial structure. Of course, this is not common, only 5% of orofacial pain, but when they occur, they cause more trouble because they are challenging, making diagnosis is challenging, and the problem can be down. Even it could be challenge in the jaw, and the brain, or in the air. So, and it manifest in the mouth. We have seen cases where somebody have eye problem and it present with toothache. So the examples of non-odontogenic pain, facial muscles can be the challenge, TMJ, maxillary gland, jawbone nerves, vessels, and could be referred. These are the potential sources of non-odontogenic pain. As I said, the major issue here is how to identify the non-odontogenic pain. These have been documented by Casey et al. 2000. And it's when you hear description of pain in this dimension, please let us begin to look deep. It may not be odontogenic pain. Number one, it has spontaneous multiple toothache, and you see it's spontaneous and it's multiple. So the other thing that can cause multiple toothache is probably cancer, maybe carcinoma and all that. But if there's no evidence of that and it's spontaneous, patient just complain of all the teeth are painful and all that, you think of non-odontogenic. If there's inadequate local dental cause for the pain, maybe there's just attrition, just a small, and then the patient is giving history of a very bad, severe pain, you know that it's more than that. If the pain doesn't follow the usual throbbing appearance, just follow the stimulating, burning, non-pulsatile toothache, it's also an indication that you could look somewhere else for the cause of the pain. If the pain is constant, unremitting, non-variable toothache, then it's also an indicator, and then persistent recurrent toothache, persistent, recurrent. And if giving early local anesthesia block doesn't stop the offending tooth, then that means that there's the pain, we have to look somewhere else. It's not likely to be odontogenic pain. And failure of the toothache to respond to reasonable dental therapy. For example, now, the dentist has done RCT, they have done the needful, and after all this, even some people after extraction, they still feel the pain. So which means that this is actually non-odontogenic pain. So not all orofacial pain are from the tooth. Some orofacial pain actually come from remote sources, from distant site, and that is, as dentist or as health professional practitioner, when patient complain of all these features to you as orofacial pain, you should know that this is referred to the specialist on time before it gets bad. Example of that is neurogenic pain, because the nerves in there will be, I'm sure we are familiar with neuropathic pain when there are pathology with the nerves itself, trigeminal neuralgia, glopharyngeal. So any of these, paroxysmal neuralgia, the pain just comes, sharp pain, debilitating pain for a few minutes, a few seconds, and then there's remission period and comes again, then we should think that this is actually a case of paroxysmal neuralgia. And the continuous pain disorder, post-herpetic neuralgia, neuritis, diaphragmatisation also will also point to, non-odontogenic pain. We are all familiar with this post-herpetic neuralgia, which after a period of about a month after the healing of herpes simplex infection, and then the pain now comes. Okay, TMJ disorder is also another one, as I mentioned earlier. The muscles are there, and then there's inflammation either from tension, from stress, from pathologies around arthritis, whichever in the joint. Then the pain can actually present. And intracranial pain disorder, we are familiar with this one also. This can present as headache several times, and other structures around can also be the one being disorder, like sinusitis, for example, salivary glands, adenitis, even nose rhinitis, lymph node, and earache. I'm talking of otitis media, and then glaucoma. These are all causes of that will present as if they are orofacial pain, but they are from the surrounding structure. So, which means that every structure around the orofacial region will be the source of the pain. Of course, when issue happen like this, we all orofacial pain actually is from odontogenic cause, as we all know that common thing occur commonly. Thank you. Others are referred pain.
Hello, Prof. We cannot hear you again. Yeah, our presenter is having challenges. Network has told us that there's heavy rain around his house. Please, let's be patient. Professor Yotola, you are back. Can you share your slide
I
again?
hope I'm back now.
Yeah, just back now.
Sorry. Okay, I'm almost done. So these are non-odontogenic pain here, as I said earlier, and the TMJ dislocation is also common, as I said earlier, and things like this. And patients, the TMJ, the condyle is out of the fossa, and it's difficult to open the mouth, as we all know, and we can reduce it as another cause of orofacial pain. Painful oral ulcer is another cause, which can be treating oral epithelium, as we say, caused by a lot of factors, or local factors, systemic, like stress is the commonest cause of this. And of course, that could be maybe systemic disease, even diabetics, or system GI lesions presenting as oral ulcer and all that. In a nutshell, as I mentioned, that the odontogenic pain can be from the pulp, from dentin, from periodontium, and all those. The one that from the pulp, caries, fracture, tooth lesion. This is just a example of what I've explained. And for non-odontogenic pain, any of these structures, the nerve itself, TMJ, intracranial pain, associated pathology, and the rest, and they can have their characteristics pain that I've explained. Management generally, we take history, we examine the patient, properly, and then you do specific investigation. Sometimes you have to do systemic examination. And the investigation, I mean imaging, the periapical X-ray, occlusal, extraoral, and the rest, will help us to know the depth and then the real lesion there and what to do. So I told you earlier, if the lesion is still within the enamel, there's a treatment you can do. If it's just near the pulp, you can do pulp capping. If it is down there affecting the pulp already, and there are treatments, CRCT and all that. Pulp vitality test also is necessary to know if the pulp is still living, let me use that word, and then if it is still there, you know whether we can have to remove the pulp or can treat. Transillumination arthroscopy, if it is TMJ, digital imaging, ultrasound. So these rest are what probably investigated. And the principle of treatment of organic pain generally, relieve the symptoms and then remove the source of the pain as much as practically possible. Give medical surgical advice. Explained earlier, we would only want to start with medical, actually if the basic acute, control the acute phase of infection, and then the treatment now follows, which can be surgical or physical therapy, as let me quickly explain. And then however, there are some prevention that will come in also that can to prevent this orofacial pain. We have to be aware. We must have what I call self-consciousness. We must be conscious of ourselves. We must know what do I have? How do I prevent it? Am I eating too much of sugar and the rest? Embrace good oral health practice. Avoid using teeth. I'm using teeth to open your crown corks. Please don't do that again. Avoid chewing the nail and all that. Avoid refined sugar. As I said, regular checkup is very important. As I said, twice a year, treat dental, control the habit and the rest. Be frequent brushing twice a day, after food in the morning and in the evening before you sleep. Dental flossing, so all these control oral habits. Use mouth guard if you are going to do any contact sport. All this will prevent orofacial pain. And now, of course, on the lighter mode, don't put more pressure on your bone, on your teeth. If you cannot eat a big bone, please leave the dogs. Let the dog eat it, because if you try that and it causes a fracture, you may end up having orofacial pain. Summary is that orofacial pain is a major public health problem, and the management can be challenging. And even the experience, because it can lead to loss of productivity, can lead to absenteeism from work, can lead to affect every aspect of our life. So it's not something that we should have. We should do everything possible to prevent it. And so prompt presentation and timely intervention at the appropriate place will prevent complication. When I say appropriate place, I mean that go to a hospital where we have dentists there, and they will be able to diagnose and do the appropriate treatment. And then with appropriate treatment, relief is very, very, very sure. So thank you very much for your attention. I'm grateful. Over. Thank you.
Thank you so very much, Prof. Oyetola. We're so happy and for this scintillating presentation. I don't know if the secretary is here to take over. Dr. Dada?
Good evening, sir. Good evening, everyone.
Okay.
Thank you so much, sir. Thank you, Professor Oyetola. Thank you, my president. Thank you for the leadership. We've listened to Professor Oyetola, and even before he started, I was looking forward to listening to him, and he has really justified the reason why he has been asked to do this. Thank you very much, sir. I want to crave the indulgence of everyone who has a question. If you want to ask orally, since we are talking about orofacial, so if you want to ask orally, then please indicate by raising your hand. But if you also want to ask by typing, we will use our vocal cavity rather to read it out. Thank you very much for this. Professor, okay, let me read some of the chats. I've seen one, maybe there were some that were there before I joined us, but Professor Adeshola Odole said, thank you, Professor Yutola, for the explicit and simple to understand presentation. I think that's one of the hallmark of many professors. They make it look simple, but just because they have the skill to bring it down to our level. Okay, so any question from Professor Manuel Fugebi, also Emmanuel Arada, also a word of commendation.
There are some
so,
questions on the chat box.
Okay, sir. I
can read them. Let me read the one.
I'll be grateful, sir.
He said, does gum chewing have any advantages or disadvantages in preventing the tooth erosion that leads to cavitation or destruction of the enamel? Gum chewing.
Professor Yutola, your attention is needed here.
Hello, I'm not hearing you again.
Okay, I want to read one of the questions on the chat box. Can you hear me?
Okay, I'm hearing you now.
Okay, so the question says, does gum chewing have any advantages? Okay, I will copy that chart and repost. So just check the chat box and then you can read it yourself. So I've reposted it.
Okay,
so
you can just tell me. You can. All right, gum chewing, right? You can just tell me.
He said, does gum chewing have any advantages?
Okay, gum chewing, all right? All right, as I said, gum chewing, the only advantage it might have is if you choose the sugarless gum. And that one may actually help to help the TMJ on prescription by the doctor. But if you chew gum chewing, and I wouldn't want to, excessive gum chewing may actually cause issue, especially when they have sugar. But sometimes the dentist may actually want to prescribe jaw exercise, including the chewing of sugarless gum. But if it is not sugarless and is habitual, it may cause TMJ problem. And even the sugar inside may also gravitate to cause oral lesion that I've told you about. So that's my response to that.
Thank you very much.
I hope you hear me, Sazamas.
Yes, we did. We heard you.
Yeah.
Let me read some. Okay, that's one. Okay. I've not seen a hand up, but let me see the participant. Okay, nobody's hand is up.
Yes, let me, moderator, let me ask a question about bone cracking. Is it healthy at all to crack any bone at all?
As I said, my last slide, if you eat bone, it's good for your head, especially as a child. But however, if you eat hard bone, the hard bone that could cause trauma, we should be very, very careful. The enamel is actually stronger than the bone. We all know it's stronger than the bone. But however, there must be moderacy in whatever we do. So that's what I would recommend. You know what fit for you, know what can cause trouble, but naturally you want to eat bone because we have minerals inside, we have things that can even make the health of the whole body better. So excess of everything is always we always counsel against excess of everything. Thank you.
Thank you, Prof. Sorry, just let me ask one more. How does chewing nails cause dental pain? Sorry, just a little bit of yes. How does chewing nails? You say nail
Chewing
chewing.
nails.
Yes.
Can you hear me? Chewing nails, as
Yes,
I
we
said,
can
chewing
hear.
nails, one is an habit. It's an habit, and it could cause problem even with teeth itself. If you remember, I posted a picture, a clinical photograph of one that have open bites, that when he open his mouth, between the upper, lower, and the lower teeth, there's a space. And because of this habit of putting foreign substances in between the teeth, it can cause more trouble for the arrangement of the teeth. The teeth will not be well arranged, and they can cause even TMJ problem at the back. And of course, can cause problems, even locally, gingivitis, periodontitis, can predispose to problems. So we always advise not to be involved in either chewing of nail, chewing of, for the fashion designer to be chewing their needles, or for the carpenter to be chewing their nails and all that is not actually advisable. Thank you.
Thank you, sir.
Thank you very much, sir. We appreciate you. It's always advisable not to use words can destroy the teeth. In one of this particular slide, sir, the orofacial pain, you talk about upset. What exactly is the reason? Is it because of the inability to cope at work, or the intensity of the pain? Do you have an idea of the exact reason why there could be absenteeism? Because I have had toothache, I was not given sick leave or leave of absence or whatever. Hello, sir. Did you hear my question? Professor Yotola, sir?
I think he's having challenges. He will still join. He's temporarily out now.
I've seen that.
Yeah. Although if you have a dentist in the house, whom they want to stand in.
Okay, I'm back now.
Okay, all right. You're welcome.
Yeah. As I said, orofacial pain has emotional component, as I've been saying. So when somebody have pain, it affects everything we do. It affects our reaction, the way we relate to people, the way we as friends, the way we relate, and even on the bed. So it's everywhere. And that is how the study has just been done to prove that it has a link. And of course, more works, more studies are still needed to establish that fact. But the explanation given in that paper is actually reasonable. I can give you the paper to go and read as well.
Thank you very much, sir. And there's something in the chat box talking about Aphthous ulcer. What is the treatment for Aphthous ulcer?
What about Aphthous ulcer?
What is the treatment?
Okay, the treatment. Yes, Aphthous ulcer is treated by one, you counsel the patient, find the etiology we have noted, and then give topical steroid. Most of the time, it goes with topical steroid, and then you control the predisposing factors. Is it stress? You control it as much as possible, and then you give topical analgesic, and then you review the patient. But the real issue there is the topical analgesic that we use, the topical steroid. And in severe cases, we may use systemic steroid, but most of the time, patients respond to topical before you now go ahead for the systemic.
So there's a question here, sir, by Henrietta Adadom.
Okay. Between the simple toothache caused by pressure and underlying tooth and a more complex neuropathic orofacial pain. Yes, I've said that again. I gave some conditions, according to occasion, how we can differentiate between the usual toothache and then neuropathic pain. By the time the pain is not throbbing, is burning, burning. Patient say it's as if somebody is writing on his face, or it's as if there is someone is putting needle all over his face. And you know that this is not toothache. And by the time this toothache does occur spontaneously, affecting many things at the same time, by the time the local pathology you see as dentist doesn't go with the way patient is presenting, sometimes you just see a tooth lesion, not even in the dentin. A patient is shouting, crying that this toothache is becoming problem for me. I can't sleep. You know that it goes beyond that tooth. So those are the points. The others are in the slide, which I will always share. So just be suspecting. When you see those conditions, those points, you know that this is not just this is not toothache. It is neuropathic pain from other sources. I hope I've answered that question.
Thank you very much. You have. Okay. Yes, you have received even a thank you from the person who asked the question. So I think it's a good and convenient time to hand over to the president to appreciate our presenter, Professor Femi Oyetola, and then to also say, before I do that, I want you to know that this is a monthly webinar of the Society for the Study of Pain. We have our webinar on the second Thursday of every month. And it's the SSPN is a multi-professional, multidisciplinary society. And we are proud to say that we're the largest when it comes to the number of professionals that are members of this group. And so, okay, I think my multidisciplinary and multi-professional thing has elicited a question. What is the role of multidisciplinary collaboration in the management of orofacial pain, sir?
Yes, especially for the non-odontogenic pain, it becomes impossible for one specialist to say, I will see everything. I just told you when I was presenting that sometimes we manage with our colleagues in mental health. We're even trying to have pain clinic to be jointly run by neurology unit and mental health unit. So it's very, very important, especially for the non-odontogenic pain. Even for odontogenic pain, sometimes we actually involve more than one unit of dentistry to look at it again. It is surgeon will have a look, and the restorative will have a look, and everybody, even oral medicine may have a look, and then we arrive. And so we are, every institution should have orofacial pain clinic. And many thanks to Professor Wotade and Professor Komolafe in UTXC. They were trying to have one now. I think we are still working on it. Hopeful it will the light of the day. So it's very, very important. That's just my word. Thank you.
Thank you very much, sir. And we as a society always encourage the establishment of pain clinic in our hospital. And we are proud of you, and we are so happy to hear this from your center. Yeah. So if you want to join this society, I will put my phone number. I'm the General Secretary, so I'll put my phone number on the platform for you to join us. Mr. President, sir.
Yeah. Thank you, the moderator, secretary, and thank you to presenter. I cannot thank you enough. Because our presenter had less than 24 hours to prepare for this presentation, and he has done it very wonderfully. And when Professor Olateji was telling me, he said it's just good to be nice. When he was asked to come and do this presentation, he said, Professor Lateju is not somebody that will ask him to do anything that he will refuse to do. So we want to really appreciate you for this presentation and for honoring our second vice president and honoring the society. We are extremely very grateful. Thank you.
Thank you. That's a privilege.
Thank you, sir. And we want to recognize the presence of our foundation president, Professor Sonia, who is here. My president, immediate past president, Professor Aderonke Akinpelu. Other members of the executive are also here. We thank every one of you for finding the time to come. I think this webinar has been very interesting and educational. I think I've also gained, we have seen it has been taken to different dimensions, and it just fits into what we stand for as a society that pride ourselves as being for multidisciplinary. So I want to appreciate every one of us for this time. And if you are here and you have not joined the society, kindly do. The phone numbers are there on the platform. And hopefully we meet you again next month for another scintillating presentation from another angle of the disciplines that comprises the Society for the Study of Pain Nigeria. Thank you very much and good night.
Good night, everyone. Good night.
Thank you very much.